Good afternoon. Welcome to the launch webinar of the pilot Cheshire and Merseyside Familial Hypercholesterolaemia service. My name's Dr. Shirley Bowles. I'm the clinical lead for this pilot. I'm consultant chemical pathologist at the County of Chester Hospital and have run the lipid clinic there since 1997. And I also run the clinic at Arrow Park Hospital for Rural University Teaching Hospital Trust, and I've been doing that since 2016. I'll now hand over to Joanne Brown, the lead nurse for the service, to introduce herself.
Thank you, Shirley. Good afternoon, everyone, and thank you for your time today. As Shirley's mentioned, my name is Joanne. My background is cardiac rehabilitation and cardiology for many, many years, and then secondary prevention within cardiac rehabilitation, where I was fortunate enough to be involved in a pilot of lipid optimization management, which led me very nicely into this FH pilot also. Thank you. We also have my colleague Julia.
Good afternoon, everybody. My name's Julia Finch. I'm the specialist nurse working with the FH project. I have come from a variety of backgrounds, almost too many to mention, but most latterly over the last 14 years, I've been working as a registered genetic counsellor with the Liverpool Centre for Genomic Medicine, and again, sidelined very nicely into this role.
Thank you, Julia. We also have one of our other colleagues, Faye, who isn't joining in today, but has been absolutely crucial with all the initial setup of the project and going forward, and certainly with her input with building the EMIS support for it also. Thank you.
Thank you, Jo. We also have to thank the Innovation Agency who've supported the development of this pilot service, particularly Tune, who has been doing a lot of work as a project manager. So as a starting point, I just want to sort of explain what we're going to try and cover in this seminar. First of all, just talk a little bit about what FH is. Then we want to introduce the service and how patients should be referred into it. We want to talk about what happens when the patients actually attend the service and how we would manage patients with FH. And then we'll give you some information about the resources that we think might be helpful and the contact information for members of the team. So just a little bit about FH, and I'm just going to use as an illustration a case that was attended my clinic many years ago, who is a very obvious case of FH. Not everyone is quite as obvious as this, but this was a 17-year-old male who went to the dermatology clinic for treatment of acne and was going to be prescribed Accutane. So they did a baseline lipid profile, and this was what was found. He was referred to the lipid clinic on the basis of this profile, and when we saw him in the lipid clinic, obviously he had a very striking family history. His mother had presented at the age of 35 with chest pain, probable angina, and this was her lipid profile at that stage when she did present. And her family history was that her father had died at the age of 51 during coronary surgery, having developed coronary artery disease in his 40s. And he had 5 sisters, all of whom were noted to have xanthelasmata, and 2 had had confirmed hypercholesterolemia. So the history in this case seemed fairly clear. So FH, according to the Simon Broom criteria, which are commonly used in the UK, this was a register of familial hyperlipidemia set up in 1980 by the widow of Simon Broom, who died prematurely of cardiovascular disease. And we have 2 categories of FH, according to Simon Broom. We have what's called definite FH, and this is based on particular lipid levels, either a cholesterol greater than 7.5 or LDL cholesterol greater than 4.9, slightly lower in children, and having tendons xanthometer either in the patient or in relatives of that patient, or these days, obviously, if you've actually got DNA evidence of a mutation known to be associated with FH. More commonly, we have what's called possible FH, which is the same degree of hyperlipidemia plus one of either a family history of premature cardiovascular disease, either in a secondary relative less than 50 or less than 60 in a first degree relative, or a family history of similarly increased cholesterol levels. And many patients fall into this category. Increasingly, we are able to put people into the definite FH category, but most of the ones that people will meet in practice will fall into this category. So FH is usually an autosomal dominant disease. It's most commonly a heterozygotes that we see. And it used to be very commonly quoted as 1 in 500, but it's probably much more common than that in most European populations. And we are looking at some places that it's as high as 1 in 200. Homozygotes, which are in fact usually compound heterozygotes, i.e. they have 2 genes, but probably not exactly the 2 gene mutations, but probably not the same one, are obviously much less common. The characteristic of familial hypercholesterolemia is they have a lifelong high LDL. So from birth, they will have relatively high LDL cholesterol levels, and this leads to the early development of atherosclerosis and cardiovascular disease. Signs of FH. Now, these are 2 signs which should raise alarm bells about cholesterol, but they are not pathognomonic of FH. They can occur in other people. So xanthelasmata, which you can see in the upper picture, these are certainly an indication to look for, so check a lipid profile, although they can be seen in patients without hypercholesterolemia, and there may be families where there's a tendency to develop xanthelasmata. Corneal arcus is probably more significant, but particularly if it develops in the younger person. And if you see a corneal arcus in someone under the age of 40, you should definitely be looking for a lipid disorder. The features that are pathognomonic of FH, that if you see these, you really are almost always talking about FH, are tendon xanthomata. Pictures A and B are what you might see in a heterozygote patient. The characteristic bumps around the Achilles tendon, or in B on the knuckles. We don't tend to see them very often, but if you do see them in association with the high cholesterol, you really have made your diagnosis. That would count as definite FH. Picture C is something very few of us are ever likely to see, and this is actually a xanthoma in the antecubital fossa of a patient with homozygous FH. As I say, these are very rare conditions, but I guess if you see one, important to recognise it. So as I said, it's usually an autosomal dominant condition, but there are a lot of different variants which can be associated with the phenotype of FH. And there's been more than 2,000 unique variants reported, of which are approximately half are considered to be pathogenic or likely to be pathogenic. Usually they affect 3 different genes, all of which are involved in the effective interaction of the LDL receptor and the LDL particle and its internalization into the cells. The commonest, accounting for the majority of cases of FH, affect the LDL receptor itself, and these are usually loss of function variants, or they are loss of function variants, and the plasma LDL is inversely related to the receptor activity. So heterozygotes will have some LDL receptor activity, but homozygotes virtually none. About 5% of cases are related to the ApoB, which is the protein that forms the core of the LDL particle and interacts with the LDL receptor. And again, these are loss of function variants. And then there are also a small number involved in PCSK9, which is a protease, codes for a protease, which is involved in the degradation of the LDL receptor. And in this case, it's gain of function mutations that cause FH. Less commonly, you may see FH in association with abnormalities of the ApoE gene, and also there's a very rare autosomal recessive form which affects the LDL-RAP1 protein, and these are both looked for when genetic testing is done for familial hypercholesterolemia. There will be quite a large number of patients who have what appears to be a clinical diagnosis of FH, but when genetic testing is done, no detectable mutation is found. The majority of these probably have what is known as polygenic hypercholesterolemia. And in fact, it is possible for genotyping of LDL cholesterol raising single nucleotide polymorphisms. This was actually done when we used to send samples to Bristol, but currently we're not actually doing that at Liverpool because it's not actually on the genomic test register. However, I think there is a plan to do that in the near future, and it can be very useful to provide patients with some explanation as to why they have a family history of high cholesterol and a high cholesterol themselves, but no absolute diagnosis of FH. The importance of familial hypercholesterolemia is that untreated, as we said, they tend to get early development of atherosclerosis, and this can have a major clinical impact. Widely quoted that if you have a heterozygous FH and aren't treated effectively, that 50% of men and 30% of women will have clinical evidence of coronary heart disease by the age of 60. And at younger ages, the relative increase in coronary heart disease mortality is enormous. The onset of coronary heart disease does vary between families. This may be due to different genetic mutations being involved, but obviously other risk factors may also run in families, and even lifestyle factors may have common maybe a common finding, such as the tendency to smoke. Generally, it's thought that as in general population, females will develop a coronary heart disease later than males. Familial hypercholesterolemia cannot be treated by dietary intervention, i.e. will not achieve effective lowering, although obviously if someone has a very poor diet as well as familial hypercholesterolemia, their cholesterol will improve if they improve their diet. It's not appropriate to use cardiovascular disease risk predictions such as Q-risk scores in these patients because it massively underestimates the risk. And the importance of it is that we do know that if you treat patients with FH effectively, they will have a better outcome, and the earlier the treatment, the better. And this is just one of the reasons why it's important to understand why someone find out someone has familial hypercholesterolemia, and also why the risk calculation may not be appropriate. This shows a study that was done looking at different levels of cholesterol, and apologies, it is in the American units, but you can get the picture that for every level of LDL cholesterol, those who have a familial hypercholesterolemia mutation have a much higher risk of coronary artery disease. And this is the evidence for intervention. We have a number of studies, but this one was looking at patients who were or weren't treated with statins and their disease-free survival. And as you can see, those who were given statins on follow-up did much better than those who weren't. In fact, these patients were fairly not particularly intensively treated. They were on an average dose of simvastatin of 33 milligrams or torvastatin 49 milligrams, but their mean LDL cholesterol achieved was around 4. And obviously, with better lipid lowering, we would hope to get even better outcomes. But even so, the effect was quite striking. This is quite an old study, but it was one of the first that looked at the effect of introducing statins in FH. These patients had all been followed prospectively between 1980 and 2006, and they looked at those before, what happened before 1992 and after. And in terms of secondary prevention, the standardized mortality ratio fell from over 500 to 388. In primary prevention, importantly, it fell to almost normal, i.e. to 103, which meant that there was no significant excess mortality, coronary mortality, for either men or women who were treated with statins prior to developing clinical heart disease. Interestingly, and this has been shown again in the updates of this work, that deaths from all causes was actually lower for patients with FH at lipid clinics than those in the general population. And this is particularly related to a 30% lower risk of fatal cancer, probably because they have healthier lifestyles and don't smoke if they've been diagnosed and attend a clinic. And I think the latest data show that their risk of actually having lung cancer is only around 20% of the general population. So this reiterated the importance of early identification and treatment, with the major benefit being in primary prevention. Unfortunately, even now it's estimated that less than 20% of patients with FH have a formal diagnosis. And this has been this concern has been the subject of a number of initiatives, not least the NHS long-term plan, which aims to increase detection rate to 25% by 2024. So this is obviously one of the drivers behind the Cheshire and Merseyside Familial Hypercholesterolaemia service, which is something I've been interested in many years. And one of the things that has been perhaps holding us back in terms of effective diagnosis and management of FH has been the availability of genetic testing. This NICE guidance came out in 2008, and even at that stage there was key recommendations included the confirmation of diagnosis by genetic testing. Until fairly recently, any business case that looked at trying to introduce an FH service had to take into account the cost of genetic testing, whereas now with the new genomic services, the genetic testing is funded at source or centrally, so that you can actually request genetic testing as a specialist service without having to pay extra costs. This has allowed us to look at recognising these individuals, confirming the diagnosis, and then going on to testing relatives using a combination of lipid measurements and DNA testing. We also have to think about children, and as part of the recommendations, we have to ensure that these patients have appropriate lifestyle advice and as well as the treatment. Now, I've highlighted the first 5 in red because these are the areas that are specifically targeted by the service that we're providing. Just a little bit more about genetic testing. We think that FH has a population prevalence of around 1 in 200 to 250. So in Cheshire and Merseyside, we would expect to be around 10,000 affected individuals. A lot more people than that will meet the Simon-Broom criteria for FH. And it was estimated in theory you would need to test up to 2% of the population to detect all FH cases. Now, genetic testing is expensive. I'm not even sure these are up-to-date costs, but certainly at one point when I was writing a business case, these were the sort of prices you were having to pay. So obviously it's not practicable to just use Simon-Broom criteria as a basis for actually testing patients. A lot of FH services which have been set up, there's been a long-standing programme in Wales, and there's been programmes in Scotland, Northern Ireland for quite some time, and some regions of England have been a little bit ahead of Cheshire and Merseyside. In order to try and improve the yield of the genetic testing, have used different a scoring system called the Dutch Lipid Clinic Network Score. And they have found that if you use a score of greater than 8, that gives you a closer likelihood of having definite FH, so that you might pick up about 60 to 80% of patients in that category. The All Wales programme has used a variation of the Dutch Lipid Clinics network score, and this is the results they've had from their testing over a number of years. And this can show, if you look at the green bars, which is the very clearly pathogenic mutations, that the higher the score, then obviously the greater the yield. So you can try and improve your yield by setting your threshold at which you will introduce genetic testing a certain score, and only allow access to that testing for the patients who achieve those scores. And this is what we have planned to use in the service. So this is the remit of the Cheshire and Merseyside Familial Hypercholesterolaemia service pilot, to offer counselling and genetic testing if appropriate, to confirm a diagnosis, then go on to do genetic confirmation, and where we have genetic confirmation, to then contact first degree relatives or offer testing to first degree relatives, and then provide advice on management according to national guidance. And I'm going to hand over to Joanne Brown now to talk a bit more about the actual service.
Thank you, Shirley. Just before I go ahead, I was wondering, do we want to ask Dr. Kemsley to join in at this point, because I'm aware that she has to leave? Did you want to give an introduction from your perspective, Sue? And then, because as I say, I know that you're double booked today and have to be in other places also.
Thanks, Jo. I've got 4 minutes. Yeah, thanks. I suppose I'd just like to say I'm really excited about the development of the regional FH service. I think the nurses and Shirley have worked really hard on producing a streamlined pathway to help the entire area. I've tried to support from a primary care perspective on how this can work best for us in primary care, and how the referral pathways and processes can fit in. We've already started doing some referrals from my own practice. So for anybody who hasn't started, I can reassure you the process works really well. The referral form's easy to use. The Welsh lipid score is really simple and quick to use in primary care, and has got the benefit that you can assess people who are already on medication to see what their risk of FH is. So I would just say that it's got my wholehearted support. I think for our patients in primary care who don't get a good service in terms of diagnosis of familial hyperlipidemia, hopefully this will help us turn it around. Thanks, Jo.
Thank you, Sue. Thank you, Shirley. So as Shirley has mentioned, we have several nurses and our colleague Faye from an administrative perspective also. So there is, initially it looks like quite a busy pathway, incorporating all the different elements from routes of referrals, both from the lipid specialist clinics, primary care, NHS health checks, and many other opportunities for practitioners to refer in. I'm pleased that Sue has recommended that utilising the form is actually quite straightforward, so you don't think we're biased with that. So for our service, upon receiving the referral, we then triage all the information that comes with that to ensure that it is an appropriate referral, and again to try to address any misconceptions. Okay, thank you, Shirley. So practices will have their own individual search tools, etc., and I'm informed that practices will often have a nominated individual to help conduct such searches in the hope of finding appropriate people to refer in. So anybody with the information and scoring a patient with the referral criteria can refer to the service, so any healthcare practitioner, or if it's a first degree relative and they can have a copy of the genetic report for their first degree relative, they can self-refer to us, again, just to try and speed up the process for them and make it a little bit more user-friendly. So just to illustrate for anybody who may have not seen yet, that when we talk of referral criteria and so on, and again, this reinforces a lot of the information that Dr. Bowles has already shared with us today. And it also links in very timely with the DES that's out there also. So many reasons why we should all be working together much more closely for FH to identify and hopefully have the appropriate individuals triaged and potentially tested by our service. So we're showing the referral form today, and it will be available via the LHCH intranet as well. We do know that there is one CCG, Liverpool, that has managed to upload this to EMIS and so on. So they have very kindly offered to assist any other areas if they need some assistance with this. So we appreciate that everyone in healthcare is extremely busy and so on. And after numerous reviews and amendments, the referral form really has been minimalised as much as possible to make it as user-friendly to everyone out there who needs to refer to us. But equally, we did need, some initial information to at least triage and consider an individual for the service. So the form will be available, we're assured, in various formats, again, to make it much more user-friendly for practitioners. There is a little bit of a pathway, a little bit more in depth on another slide. But basically, yes, the clinician out there, whether that is nursing staff, medics, lipidologists, and so on, would score the original criteria and the Welsh score, and then forward that on the referral information to our service. And then we will hold basically almost a triage sessions amongst ourselves, and again double check the Welsh score, just because again it's new and whilst people are coming to terms with it. So it is quite user friendly. It is supposed to be very quickly to use also, and then should give us the score. So we have the criteria score, again, just to aid practitioners as to who may be appropriate and who may not be. But equally, as we all know, individual patients come with all sorts of different circumstances. So we are trying to be flexible, that if a practitioner feels there is an individual who isn't quite scoring 6 or above, if they were to contact us to feel that this patient definitely warrants discussion and so on, we will be flexible, but obviously we have to keep that to a minimum. But the Welsh score is there as an initial almost gatekeeper. So then once we accept the referral, the patient is then contacted to confirm they actually do want to go ahead with the process and the appointments. So then they're booked in, and at the moment we don't have any waiting lists. So they normally have an appointment within about 2 weeks or so. So the appointment that they have is a very, very comprehensive appointment. It isn't just a case of we telephone someone and say, oh yes, would you like to be tested, and send forms out. We do go through past medical history with them, side effects, if they are particularly already on lipid lowering therapy, to see if they've had any issues, because as we all know, there are a lot of misconceptions out there with individuals and their medication and potential side effects and so on. So the appointments at the moment are held remotely, because as Shirley demonstrated, we are covering such a vast area and there are only 2 of us. And actually what we're finding at the moment is some patients quite like the flexibility of having a telephone or a virtual appointment, because we can fit it in a lot more with their time scale. So some of these patients may not be feeling, may not have any diagnosis of any medical history, and therefore find it difficult to free up a day or half a day to trek across the region to be seen. So the remote appointments are working really well there. So we will clarify their past medical history with them, allergies and so on, medications that they're currently taking, and, as I mentioned, any issues that they perceive with any lipid lowering therapy that they may be on. They are also given a link to go on to a portal called FamGenics, where both the individual and the team can access this, and we can see there's an example of a pedigree tree that can be drawn up as well. So the appointments that we take every opportunity to do full risk assessments, like Shirley mentioned before, because these patients, whether they are found to have the genetic variant or not, many of them will be coming from families with extensive history of premature coronary heart disease. So we do feel it's important to take every opportunity to look at lifestyle and reducing risk factors regardless of the outcome also. So it isn't a quick appointment by any means. It's taken extremely thoroughly, and a lot of the patients, a lot of their issues will actually be about the impact to their loved ones. So there'll be many parents worrying about their own children, and a lot of the time the discussion will be around them as opposed to the actual individual, which is why they need to feel that they do have time to be listened to and answers given. And again, you know, part of our role is to emphasize all the pros and cons of having such tests and the implications, both financially also. Now, there are some employment opportunities that would have used this as a barrier at one time, such as the armed forces, but we're led to believe that that is no longer the case. But again, in gaining full verbal consent from an individual, we do feel it's our role to point these things out. Along with that, we're also pointing out, you know, the potential outcomes of such tests. And we can see from looking at the slide that there are options for a blood or a saliva test, depending on the patient and their preferences. So if we agree that the patient does meet the criteria and they give consent, we will then arrange for a kit to be sent out to the individual, and they can normally take this to their local phlebotomy clinic or their local GP. The patients that we've dealt with so far do not appear to have had any issues in having these bloods taken. And in the pack that we send to the individuals, we send them a very thorough information leaflet so that the practitioner taking the blood knows exactly who we are, what the sample is for, and then where it goes, i.e. to the lab, to be posted to the lab. So once the test is taken, our service will then contact the patient approximately 6 weeks down the line, just to ensure it all has gone ahead as planned. And at the initial consultation, the patient is reminded that the process is fairly lengthy, 8 weeks or thereabouts. So it isn't, you know, the results are back in a couple of days. And this can be quite important as well if a patient is particularly anxious. And again, they are advised that they can telephone the service if they want to discuss any other points during that time. So the results are then fed back to us in the service, and we relay those back to the patient, and obviously any added support that may go with that. So if a patient is found to have a variant, you know, next steps for management, etc. We remind them that they can tell their first degree relatives to directly contact us to discuss testing also. And then a letter of the outcome will be forwarded to the original practitioner who referred to the service and to their GP to keep everyone up to date. As Shirley mentioned, sorry. Shirley. So it was just to emphasise, as you have mentioned, so currently, when we know the outcome, a letter of recommendation will be sent to the GP if it's definitely is for lipid lowering therapy. Again, you know, for the patients who are found not to have a variant, there may still be lifestyle improvements there. But the hope is in the long term that we may actually be able to move onwards to possibly, you know, prescribing, monitoring, reviewing of medications, but that's a much longer term goal.
Thank you, Jo. Yeah, as Jo has said, at the moment we're not in a position to provide ongoing monitoring of these FH patients, but we are keen to support primary care in ensuring that patients do get access to best practice in terms of the treatment of this condition in order to optimise their clinical outcomes. So with this in mind, on discharge from the service after they've had the diagnosis either confirmed or excluded, we will provide a recommendation regarding a management plan, and this is based on national guidance which has been compiled by the Accelerated Access Collaborative and is a combination of all the recent NICE guidance on lipid management. We are hoping that we may be able to provide an advice and guidance component, so maybe allowing clinicians to contact the service for advice on individual patients. And we will probably do some follow-up of patients in order to look at to provide audit information on outcomes so that we can inform the future service model, because obviously, as I said, this is a pilot and we will be looking to try and commission a long-term permanent service. Obviously, during the course of cascade testing, we may find children, and there are recommendations as to how children with FH should be managed. There is also a child parent pilot screening programme ongoing. A few sites within the region are involved in that, and obviously as a result of that, children may be detected with FH. And we are in discussions with Professor Joe Blair at Alder Hey Hospital to pull together a paediatric pathway managing such patients. Having mentioned the summary of the National Guidance for Lipid Management for primary and secondary prevention, this is the front page of that guidance. It's pretty comprehensive, covering primary, secondary prevention and severe hyperlipidemia. I'm not proposing to go into that in any detail at all. It's just so that you can be aware that it's available and very readily accessed through just by there's a link on this set, but obviously you can just Google it and it will come up, and it's a very good way of basing your treatment of patients regardless of what the cause of their hyperlipidemia is. So back to the main recommendations of NICE Clinical Guidance 71, the bit that the service is not dealing with is this relating to the treatment other than an outline management plan. But the recommendation for patients with FH is to achieve a reduction of LDL cholesterol of at least 50% from baseline. The family hyperlipidemia component of the national guidance I showed you is outlined here, and this is about identifying patients who may have FH, referring on to a service for genetic testing, and the treatment targets. And just to summarise the treatment targets, you look, as I said, as NICE said, you're aiming for at least a 50% reduction in either non-HDL or LDL cholesterol from baseline. But of course, if a patient has already got existing cardiovascular disease, you are going to use the guidelines related to secondary prevention, which are going to probably give you much lower targets than that. Some of these patients may need to be referred to specialist clinics. That may be because they're not managing their treatment, or because they are extremely high risk patients. So it is recommended that if a patient has established coronary heart disease and or two or more risk factors, that they may benefit from attending a lipid clinic, or if despite being on optimal tolerated treatment, they still have significantly elevated cholesterol. So an LDL of greater than 3.5 millimoles in secondary prevention or 5 in primary prevention, these criteria would entitle them to, according to NICE, prescription of additional therapies such as a PCSK9 inhibitor. Just a reminder about statin intensity. Obviously, if you are going to be trying to achieve 50% reduction in LDL cholesterol, you are going to be using the more potent statins such as atorvastatin and rosuvastatin, and you may require moderately high doses. In primary prevention, I would still tend to titrate upwards, partly because there's quite a variable response with patients, but also if you put a patient on a high dose of a statin and they have any side effects, you may then have problems convincing them to take statins at all. Whereas if you start on a lower dose, you're less likely to get side effects on a lower dose. And even if you don't manage to get them onto a sufficient dose of a statin, you at least have got the chance of having some lipid lowering, and you can obviously always add other medication if necessary. Just point out that the same Accelerated Access Collaborative has also produced a very good statin intolerance pathway. I'm not proposing to go through it in any detail, but it is a way of approaching patients who may have developed problems when they've started on statin. We will provide our patients with a lipid passport from the service so that they can keep a record of their cholesterols. We'll make it very clear to them what their target is, and although the targets may change according to research or to their clinical circumstances, we will provide them with a target at that point and encourage them to take control of their subsequent monitoring and make sure that they are having their lipids checked and that they are at the target that is required. And just to finish my part of this presentation, I just wanted to talk about a patient that I was involved with, again, through the lipid clinic quite a number of years ago initially. This was a 16-year-old initially when I first saw him. His mother actually attended the lipid clinic, so we took the initiative to get his lipids done when he was only 16. And as you can see, he had a very significant hyperlipidemia with a cholesterol of over 11 and LDL cholesterol of 10. He had a very characteristic family history. As I said, his mother was already attending the lipid clinic. His grandfather on his mother's side had had a myocardial infarction at the age of 57, and his maternal uncle had had bypass grafting at the age of 60. Initially, we gave lifestyle advice to this young man because it was quite clear that his lifestyle was not particularly good. It was possibly fairly typical of a teenager, and he actually managed to achieve quite a good degree of lipid lowering just on the basis of dietary changes. So his LDL dropped from 10 to 8, but obviously this was still far from where we wanted to be. So over the next few years, we did try giving him treatment. He started on simvastatin 20 milligrams and then went to atorvastatin 10, 20, then 40. Unfortunately, through this time, he wasn't very good about taking his treatment. His diet varied considerably from being not too bad to being terrible. And the best LDL cholesterol he achieved over this period was 6.1 millimoles per litre. At the age of 18, 19, he went to university, and although we tried quite hard to keep a track on him and offered him blood tests during his holidays, he really disappeared off the radar. He then, almost 10 years later, was re-referred to the lipid clinic. He was a much more sensible 28-year-old at this time, by the stage, and was very keen to address his cholesterol. He hadn't really had any treatment for most of the intervening period, but he had started atorvastatin 40 milligrams about 7 months earlier. However, when we saw him in the January, his cholesterol was appalling. It was higher than it's ever been. And by this stage, he'd also developed xanthelasmata and xanthomata, which he had not had when he was 16. I think some of the problems with his cholesterol was related to Christmas, New Year, and that's an important point to note with any patient who you're seeing with lipids, that lipid profiles done in January are not particularly helpful when you're making assessments about future risk. Anyway, by this stage, this patient's mother, who I think had moved to another area and had managed to access genetic testing, and she had been shown to have a PCSK9 gene mutation. So we were able to confirm that in his case. By the October, we'd got the confirmation of the genetic mutation. By that stage, he was also on atorvastatin 80 milligrams, and although there had been quite a marked improvement, his results were actually almost exactly the same as they had been when he'd first been diagnosed at the age of 16. So at that stage, we made the decision to start him, in addition to atorvastatin, the PCSK9 inhibitor evolocumab, 140 milligrams taken subcutaneously every 2 weeks. So he has complied very well with that treatment, and this was the outcome. So having been started on evolocumab, as well as 80 milligrams of atorvastatin, he has a very good lipid profile. And hopefully, despite the lost 10 years, we'll have a good clinical outcome as well. So just to summarise, the vision of this service is to provide a pathway for the identification and agreed and effective management of FH, ensuring that all patients within Cheshire and Merseyside get access to best practice as outlined in the NICE quality standard on FH. We want to identify individuals at risk of FH, triage those as to suitability for genetic counselling, and, if appropriate, test for the variant genes, facilitate cascade testing of relatives, support individuals and families throughout this, and provide advice and support to the referrers according to them to ensure optimal management of these patients. And that we are going to be providing ongoing support in terms of further webinars, virtual drop-in sessions, and maybe some local visits, meetings in the various areas within our region. And this is just a list of educational resources that we can point people to. We'd also like to mention a course that's run by the Royal College of GPs, which is to do with FH. And this is just the contact details for the service should you wish to refer your patients. And I'll stop at that point, and unless Joe or anyone else within the service has anything more to say, we can open to questions.
No, Shirley, I've just added that point just to emphasise that we will be trying to contact patients approximately 4 months after their genetic testing if they are found to have a variant, just to ensure that they are being, titrated, reviewed, etc. locally, rather than assuming that's the case.
Thank you. I think it's very informative. We have a few questions in the chat, so perhaps we can go through them first. There's a question regarding if EMIS is developing the Dutch Welsh lipid score within a medical record as per the Q risk. I believe we've talked about it in the past. Shirley or Joe, would you like to comment?
Sorry, I'm just trying. Are you still seeing my screen, or have I?
Yes, we can still see.
Yes, we're still seeing it.
I'm trying to stop it now. Can't get the screen back, the thing back up again. Apologies. Okay, is that better?
That's fine. Yeah.
Okay, sorry. Could you repeat the question? I was a bit distracted there trying to.
Of course, Jonathan, I can see you have your hand up as the question came from you. Would you like to ask it in person?
It's a different Jonathan.
It's a different. I can see it now. Sorry. So there was a question. We have the right Jonathan on screen now.
Yeah, it's whether if this has been done in Wales. I know Wales have different medical record systems, but are we talking? I don't mean we personally, but NHSE talking to EMIS and the medical record providers to have this integrated into the medical record. I mean, I looked at my own EMIS and there's no Welsh score within that. There's not even a Welsh score SNOMED code. So are we trying to kind of integrate it like there's Q risk, there's Q cancer, there's Q fracture, but it seems to me we're missing a trick if we're not going to have a Welsh score within those GP medical record systems.
So, Jonathan, just recently, Liverpool CCG have managed to upload the referral form, the Cheshire and Mersey service referral form onto EMIS, and that's going to be one of our next steps after today. They've been really helpful around that. and they have, you know, offered assistance, if you like, for any other areas that may need some guidance on uploading that to EMIS and so on, so if that will help.
Thank you. Then look like to move on to the following question from Fiona. She asks, do we need to repeat trigger level if this was not fasting, or can we put a value in and stay non-fasting on this on the referral? The Wells lipid score asks for fasting trig.
I mean, from my point of view, I think if you've got to the point of actually thinking about a patient having FH, if it's a patient that, if I'm sort of assuming a patient that's not been treated previously, we do obviously advise having at least 2 lipid profiles before you actually consider referral, because we would never think it's appropriate to manage a patient on the basis of 1. And I think the LDL cholesterol, which we do tend to use a lot in all the assessments, is really only valid, the calculation of it is only really valid in fasting specimens. So my feeling would be that unless you had a patient who was not able to fast, which might be, say, a patient on insulin, etc., I think that second blood test should really be a fasting one, and then you can get both a more accurate LDL cholesterol result and a fasting triglyceride level.
Okay, thank you, Shirley. I hope that answers your question, Fiona. We have another question from Greg, who asks, could we clarify how GP teams will be informed regarding the service and how the referral form will be uploaded onto the GP medical record systems? Joe, you are on mute.
Oh, sorry. Probably the best way. We mentioned before there will be ongoing, you know, communication opportunities such as today's. Today's is the initial for primary care. We have previously done a launch with the lipid clinics, and again that was to stagger referrals coming in. We have mentioned that we will be there will be other emails to come regarding the referral forms and having them uploaded onto EMIS and so on. And again, just ongoing in communication to increase the awareness out in primary care. We would be interested in perhaps devising, if not a weekly questions and answer session, maybe fortnightly, depending on what practitioners feel is realistic.
Okay, thank you, Joe. Does that answer your question, Greg? I can see you have your hand up as well.
Yeah, I've got my hand up just to give a suggestion. iMersey are the people who upload documents. Well, certainly they do in Sefton. So that, you know, if we want to increase the uptake, really that's the way to get it out there. And I'm sure every place-based conditioning area has communication channels to practices, and you know, that's
absolutely,
the way to get it out there.
Absolutely, Craig, and we've already linked in with iMersey, and as you say, they've been extremely helpful. And once they knew about this webinar today, it was actually them who suggested have the webinar and then the next step with the forms for EMIS, etc. But thank you.
Thank you. I can see a few people have their hand up as well. So just move on to the next question on the chat, and then I'll give people opportunity to ask a question. So one question is, some of the GPs are involved in the child parent screening project. So how will link this service in? Shirley, would you like to comment?
Yes, well, as I did mention that we are working with Joe Blair on a paediatric pathway. The child parent, obviously, they're going to be identified very early in life, not long before you would actually actively treat them. So the parents will probably be, if the child is diagnosed, then obviously at least one of the parents is also going to be diagnosed, and they will probably be referred into the pathway as adults. We've got to just try and work out how we maintain contact with these children until they're of an age where we start initiating treatment. Unfortunately, Sue Kelmsley is involved in the pilot service, the pilot child parent, she's had to leave us. But there will be a paediatric pathway which will take both these patients and the children that we pick up via the adults during cascade testing.
Thank you, Shirley. There are two questions, one from Thomas and one from Fiona. But before I address them, I would like to give the floor to Michael Clark, who also has his hand raised.
Just coming on, Mike Clark, GP over in Macclesfield. Apologies if the dog's whining in the background, but just a combination question. First of all, it was being over in Macclesfield. We've historically referred into Manchester. So is it the ICB's intention that we tend to send all of the patients through to the Mersey service? Excuse me. And if so, I mean, it makes sense if it's a telephone or virtual referral. But if some of our patients are still in the system in Manchester, are they likely to be having different criteria used to assess them?
I mean, if you say they're in the system, do you mean they're actually already under the lipid clinic, or?
Yeah, so if they've been assessed by a lipid clinic before in Manchester and we're talking about a referral on, it makes sense maybe to refer them back into the Manchester system. But if it's a new patient, obviously, if the ICB's intention is that we try and send all of our patients through to the Cheshire and Merseyside service, then fine. We just need to know that that's the intention.
Well, I think if a patient's already under a lipid clinic service, then they will probably access the genetic testing, if it's appropriate, directly. I mean, we are encouraging, I mean, I've obviously run lipid clinics. I am referring my patients, rather than testing myself, I am referring them now. I have done some testing, but I'm now referring them to the FH service so that they get all the support. But if they're under a lipid clinic service, I guess they would have their own approach as to how they would do it. So I think if they're under a Manchester lipid clinic, then unless they're not getting access to testing for some reason, you would probably leave them there. If then patients that are sort of fresh to the scene, if you like, then yes, I guess it would be appropriate to send them to our service.
Sorry, just a quick follow-up. It was trying to envisage a potential issue where we may have patients, some in the Manchester service and some in the Cheshire and Mersey service, and are they potentially going to be assessed for the referral under different criteria, or is it likely that the Manchester service is going to use exactly the same criteria as the Cheshire and Mersey service? And it was also partly then about capacity, whether there's enough capacity in the system for all the referrals that might come through because of the DES, the IF. So again, are we going to eventually have an issue with capacity for having patients assessed in the clinics?
Well, obviously this is, I mean, I can't say for certain what the Manchester service is going to use for criteria. As far as capacity is concerned, obviously this is a pilot, and the plan of the pilot is to provide support for commissioning a full permanent service. And part of the pilot is sort of assessing demand, really, and trying to, establish how big a service is required to meet the demand that's out there. I mean, it's difficult to judge because you sometimes get a whole deluge of patients being referred at the beginning, and then you may get it all sort of settling down to a steady stream. But yes, I mean, we can anticipate we're going to need more capacity than we have at present. But that's the purpose of the pilot, really, to try and assess what the service does need to look like, and what configuration it should have to meet the demand out there.
Thanks.
Also, Michael, just to add to that, sorry, before we move on, in the few months that we've been together as a service, we are really trying to network with all the highly established services and improve communications and so on. So the likes of the South Manchester service, we have a really good rapport with them. So if there's any queries whether an individual or a family should be under this service or that service, we've already built up good communications with whether they could just give us a telephone call as well to double check and clarify. And similarly, we're meeting up with the Blackpool services next week as well. So we are trying to sort of pave the way for smoother access on various levels.
Great, because I mean, it is the South Manchester service that we normally use, and so again, if everybody's mostly singing from the same song sheet, then great. It just makes life easier. Yeah.
Absolutely. Thank you.
Thank you very much. I'm mindful of time, but I would like to go through these two questions that are in the chat. One is from Thomas at the Orchard Surgery. Joe, perhaps you could answer this. What is the current waiting time for the service? And should we prioritize and stagger refer to avoid the service being overwhelmed? For example, oldest patients first.
So currently, we're probably looking around the 3-week mark by the time we receive the referral, contact the patient, gain their consent and so on for an appointment, depending on postal services as well. But again, we're looking to address that. So at the moment, it is minimal. Yes, there is a possibility that, you know, we may be overwhelmed, but again, with Shirley's experience and discussing with our colleagues in the Welsh services, they when we asked them when they went through this, they said there was an initial flurry, nothing that wasn't manageable, and then things sort of even out a little bit. But obviously, as we say, it is a pilot, and if we do develop an unmanageable waiting list, then that will all be accounted for in the evaluation documentation that goes ahead, and the recommendations, hopefully for the longer term service that we hope will result after this.
I think that's important to mention that we will be an evaluation as well. So we'll take that into account. Thank you, Joe, for answering that question. The last question in the chat is from Fiona from Middlewich Road Surgery. She mentioned that their lab uses non-HDL. Is this as good? I would like to answer that question.
So the lab only provides non-HDL cholesterol and doesn't. I would be surprised if they aren't able to provide an LDL cholesterol at all. We only tend to provide LDL cholesterols at our lab if they've been. We have two lipid profiles. You can either ask for a random one or a fasting one. If it's a fasting one, then you can. Then you'll get your LDL cholesterol. Otherwise, you'll get a non-HDL cholesterol only. But most of the criteria do require LDL cholesterols, or all the criteria use LDL cholesterol rather than non-HDL. I noticed David Aliski's got his hand up. He may have some insight into this.
Well, I was just going to say that we have two profiles. We have a random profile that doesn't include LDL cholesterol, and we have a fasting one that does. While an initial screen, it's reasonable to do a random test for assessment for referral for familial hypercholesterolemia. Genetic testing, we need an LDL cholesterol and we need a fasting triglyceride in order to assess through the Welsh score. So if you are considering for this, please ask for a repeat as a fasting lipid profile, then you will get the fasting triglycerides and the LDL cholesterol that you need to make the assessment.
Thank you, David. That's exactly how it is in our lab. We do a lipid profile that contains an LDL. Well, all our lipid profiles contain both contain triglycerides, total cholesterol, HDL cholesterol, non-HDL cholesterol, but only the fasting will give you the LDL, and that's related to the Friedewald equation, which is used to calculate LDL cholesterol, is only really valid in fasting specimens.
Okay, thank you for answering the question. I hope it was useful, Fiona. That's it in terms of questions currently. Is there anyone else who would like to raise their hand? If not, then I think you can conclude this webinar. Thank you very much for everyone involved in presenting and attending. I hope it was useful and informative. We will be in touch with recording as well, so you can share this with colleagues or watch this back at another time. We also will be sharing the slides from this presentation, so you have all the references at hand as well. And I think that's it from my end. Shirley, Joe, would you like to add anything to that?
I'd just like to say thank you for attention, and I'd be very grateful for any feedback if you feel that the material that we covered is appropriate, or whether we need more or less background, etc., just to inform further presentations in the future.
Yes, thank you everyone for your time. And if you do have any queries, please email us, telephone us. we'll always return your query, etc. And it would be wonderful to hear from you. Thank you.
Thank you. So our contact details will be in the slides that we will be sharing. So that's the best way to find us if you haven't our contact details already. Thank you very much, and I wish you a good remaining rest of the afternoon.
Thanks, Tom.